cancer. And I just thought that's one thing that everyone often reports, but what exactly do we report and what exactly do they want us to sort of let them know is the question. So here's the first case, and why don't one of you just describe the findings and we can discuss it, okay? So ignore the fibrobronchiectatic changes and all of that. Yeah, so that's post-infectious, ignore that. Let's talk about ovarian cancer only, okay? Yeah, so what do you say? I'm going to scroll down. Okay, and you can ask me to scroll up and down depending on, what you feel like. Who's going to take this?
Sir, I'm Aparna. I'll be taking this.
Okay, fine, Aparna. All right. So, okay, I'm scrolling. Okay, so you see anything in the chest? Let's just talk of the chest first. Okay, so this is basically a patient, a 50-year-old lady who has a distended belly. She comes for ultrasound. We see, essentially a lot of ascites and omental nodularity, fat stranding. The CA-125 is highly raised. Okay, so this is essentially ovarian cancer, right? Okay, so you can see the adnexal masses. So the diagnosis is not the question here. It's just about how would you report such a scan? What do you search for when you report ovarian cancer? Okay, so yeah, you want to just start with what do you see in the thorax?
Yes, sir. Can you scroll down and the chest once more?
Yeah, I'm scrolling down. Do you see anything here?
So there is an hypoenhancing soft tissue lesion in the left breast.
You're talking of this, or what are you talking about? This stuff
Yeah.
here, this soft tissue?
Yes, sir.
So you look at the other breast as well, and I mean, do you see something like that? Maybe not, it's asymmetric, I agree. But do you see a mass here?
No, sir. No.
I think this is, most of it at least. Do you
You
think
must.
all of this is mass here and all of this is mass on the right side?
No, sir. It looks like normal breast parenchyma.
Yeah, so this is breast parenchyma, right? So, I mean, if you see a well-defined enhancing lesion, which is, a well delineated or speculated, certainly that can be a breast primary, or CT is not always great in sort of differentiating a fibroadenoma from a breast cancer, but at least as a breast lesion, right? Here I would tend to ignore it. I agree it's asymmetric, but I think that's more to do with the positioning of the lady than anything else. Okay, but there's something else, but that's okay. So we'll go down further. And so give me some positive finding apart from the fibrobronchiectatic changes in the lungs. Is there anything abnormal in the chest? So what's that? What do you think is this?
That is the liver on the lower section, sir, and there is fluid.
There's some fluid, right? So
There
what is
is
this? What is this?
yeah,
So this is the liver. What do you think is this? What is this structure?
that is the diaphragm.
Yeah. Yeah. So this here is, in the abdominal cavity,
Ascites.
it's very hepatic. But what is this?
That is right pleural effusions.
Yeah, it's effusion, right? So there's some effusion there, right? It's sort of loculated. I mean, you expect it to be here, which is not the case, but but there is some effusion, right? I think we can agree to that. Okay, so one thing you remember with breast cancer, Aparna. So, sorry, with ovarian cancer, the most common site of Mets are two actually. We all know of peritoneal spread. The other thing is nodes. Okay, so ovarian cancer very rarely will go to liver, lung parenchyma. You won't see visceral metastasis per se, but like all other carcinomas, it does go to nodes. So the two common sites for ovarian cancer is always going to be nodes and peritoneum. Okay, so now keep that in mind. I'm going to scroll again and now search for nodes. All right. So when you scroll from top to bottom in an abdominal case, at this section, which node are you searching for? Most abdominal cancers go to which node in the
Left
yeah.
supraclavicular.
Yeah. So you see a small node here. I don't say it's huge. I wouldn't say it's huge, but there is a node here. Okay. So you would mention it in the report. Okay. That there is a node here, which is, what? It's not super big. It's around 9 by 6 or something. But you mention it because we know that ovarian cancer spreads to nodes, and because of findings that you'll see later on. Yeah, now I'm going further. So all these nodes you tend to ignore. Okay, so you can expect small mediastinal nodes in pretty much everyone, right? So you don't worry too much about the mediastinal and the subcranial nodes unless they are really big. Okay, so these I will ignore. I will not really worry about them. I won't mention them in my report. Okay, but do you see any other node? Okay, so I'm stopping at this section. So this one is a little tough. I mean, in the sense it's not, so every Tata person will catch it because we are so used to seeing breast cancers, and this nodal site, the hint is that it's a site of drainage of breast as well. Can you search for it now?
Internal mammary nodes.
Yeah, perfect. Right. So you
Left
see,
internal.
right? So that's big, right? I mean, generally we don't see nodes in the internal mammary region, or we see some tiny ones, like you can see this one here, but that's pretty tiny, right? I hope it projects well, but you can see a tiny node here. Okay, but this is pretty big, right? That's abnormal. So this one we would definitely mention. And once I see big nodes elsewhere, then I'm more worried about the supraclav. Okay, so I still don't know. Supraclav is indeterminate. I'm not saying that it's metastatic. This one certainly looks metastatic. Okay, then the other thing is going to be epicardiac or epiphrenic nodes. Okay, so normally you would see some smallish nodes often. So this one I'm not that worried. They are small, sub-centimeter sized. Okay, but sometimes they can sort of be big. Okay, epiphrenic is a different one to differentiate because they are drainage size of peritoneum, which means that even mildly enlarged nodes can be just reactive to the peritoneal disease, or they can actually be metastatic. So it's difficult to be sure. Okay, but this one, yes, this is pretty small, so I'm not worried about that. But internal mammary, yes, this one I think is definitely looking worrisome. All right. So remember that. So ovarian cancer, definitely look at peritoneum, but also look at nodes. Okay, and the third thing to look at is pleura. So for staging, stage 1 and 2 are essentially local disease, limited to the ovary or to the adjacent pelvic peritoneum. Stage 3 is when it goes into the abdominal cavity or the peritoneal cavity. And stage 4A is, do you know the stages? Let's see if you know 4A. You know what is 4A and 4B stage in ovarian cancer? Any idea? It's okay to not know. I mean, that's not a, something that I expect a resident to know.
Not sure, sir.
Okay, fine. So stage 4 is when it goes to pleural.
Distant organs.
Pleura. No, pleura. 4B is distant organs. Okay, so 4B is when there are liver mets and lung mets. So basically anything beyond the peritoneum and the pleural surface becomes 4B. But 4A is when there's only pleural involvement. Okay, so just effusion does not necessarily mean pleural involvement. So you have to tap it and prove that it has malignant cells within it, or you actually see, peritoneal pleural thickening nodularity. Then you can say, okay, fine, this is metastatic. In this case, we cannot say. We can just mention it as effusion. We don't see any pleural nodule or thickening. So this, unless they tap and prove it, we don't know. Okay, but that's something to look for basically. So my point is that that's your search pattern. Okay, so you can see a node here now. You see this?
Yes,
Right?
sir.
Unless you search for it, you won't see them. Okay, with ovarian cancer, we all look at peritoneum very nicely, but we forget that nodes are equally common, or I mean, or almost equally common. Maybe peritoneum is slightly more obvious, and they are big, but almost half the ovarian cancers will have at least micrometastatic nodal disease, if not more. Okay, now there's one more nodal group that you will see here, which is a little bigger than usual. So which other group do you see here? I'm scrolling. This is again, I'm still talking of thoracic. So which part of this image is in the thorax or thoracic cavity? Let's stop here.
The para-aortic
Yeah.
retrocrural
Excellent.
node.
That's the word, retrocrural, right? So this is the crura and this is retrocrural. And again, you should just search for it. Okay, so remember, so all cancers or all pathologies, you need to have a search pattern. And for that, you need to know where will it most likely go, right? So in a regular case, I'm not going to focus on retrocrural region per se. But in every case of ovarian cancer, I'm going to look here because I know that ovarian cancer has a propensity to go to nodes, and it can actually go to any nodes. I've seen isolated axillary metastatic adenopathy as well. So it can go anywhere. So this again, you need to mention, okay, that there are suspicious nodes in the retrocrural. You see a bunch of nodes there, right? They're not super big, but it's not a single tiny node. You see
Yes.
a bunch of prominent nodes. And just because it's so many of them, you are sort of more worried. All right. So that's about nodes. Excuse me. Now let's go to the main thing, which is the peritoneal cavity. Right. So you have any, so if I ask you, or rather, suppose, a surgeon calls you and says, okay, I've sent this patient for ovarian cancer. I think you have done a CT. So the surgeon already knows, right? The patient is ovarian cancer. CA125 is raised. There is a lot of ascites. Why have they done the CT? What specifically are they looking for? Why can't they just operate and open the abdominal cavity? They'll anyway see everything in the peritoneum and they can operate it. So what are they looking for in the CT scan?
So peritoneal deposits and staging, sir.
Fine. So one thing is staging. They want to know whether it is 4B or not. If it's 4B, meaning there is visceral metastasis, they obviously will not operate, right? Then it's beyond what, an abdominal surgery will be able to treat. Okay, but it's not just that. They also want to know whether it is, even if there's only limited, if there's only peritoneal disease, only stage 3, they still will be looking for whether it is easily operable or not. So there are certain specific sites in the peritoneal cavity which they'll ask you that do you think it's involving X site or Y site? Which sites should you specifically search for in the peritoneal cavity? Okay, so what we'll do is we'll just go through this and you tell me where do you see deposits, okay?
Yes, sir.
Okay, so we are going down now. So just keep describing what you see. Do you see anything abnormal till now apart from the ascites? There's ascites. Do you see any deposits?
Sir, on the hepatic surface, there are deposits.
Excellent, excellent. So you see some deposits here, right? Subdiaphragmatic or hepatic,
Subdiaphragmatic.
call them.
Yes.
Fine. So certainly there are some deposits here. I hope it's something that everyone can see well. But there are certainly deposits here, and often you should do a coronal recon and you can see them better. We can try it towards the end. Okay, now I'm going down further. What else do you see?
There is
Mm-hmm.
omental nodularity, sir.
Okay, so where is the
And
momentum here? Where is the momentum? So which momentum do you see here?
the lesser omentum, sir.
Excellent, right? So this is the lesser omentum, right? Excellent, very good, very good. So lesser omentum is basically the lesser sac, the fat in the lesser sac behind the stomach, anterior to the pancreas. All of this is abnormal, right? That's all soft tissue here. And lesser sac is one thing they want to know because it's not easy to resect it. Okay, it's not the run-of-the-mill straightforward omentectomy and sort of cytoreductive surgery. It's a little more complicated than that. So this is something they want to know. Okay, so good you caught that. Okay, there's also sort of, the greater omentum sort of starts here. So maybe this is also mental, maybe. So some amount of left upper quadrant deposits. Anywhere else? Do you see any other deposits here? Okay, so I'm going to rotate here till you see it.
So, sir, along the falciform ligament.
Lovely. Very good. Very good. Okay, so you can clearly see. Okay, so what I'll do is maybe I can window it better. How do I get it? Yeah. Yeah. Okay, so you can clearly see this. This is deposit along the falciform ligament. But is it just falciform or where else is it going, right? You can see it's sort of going, reaching here. And what is this? Here, right? You see this? There's something in the hilar
Yes,
region.
the periport.
Yeah,
Yes.
portal or hilar region, right? And that is again something very difficult for them to resect. So this you should tell them. Okay, so when they call and ask you, what do you think? You just can't say there's peritoneal disease. You have to say there's peritoneal disease, but it's pretty extensive. And there are certain sites where I think you'll find it difficult to operate, like the lesser sac, like the perihilar or the periportal region. These are difficult for them to operate, so they need to be aware of it. Okay. You see a big deposit here, right? In the gallbladder fossa. Okay.
Yes, sir. Yes.
Yeah, good. So now we keep scrolling down, and now you see peritoneal deposits also. For example, this one is a peritoneal deposit, right? This one, these are all peritoneal deposits. Okay.
Yes,
So
sir.
actually, what is it? Whatever is anterior is going to be omental deposits. So all this stuff that you are seeing now. So how would you describe this? If you need to describe it, what would you call it?
There is nodularity and thickening of the omentum with caking.
Yeah, excellent. Yeah. So caking is a good word to use. So omental caking or sheet-like omental thickening, or so nodularity I generally, so this is what I do. Okay. I don't think there's a hard and fast definition of what to do. But there are a lot of stuff in the chat box. I don't know. I hope everyone is able to hear me. Anyway, so what I generally do is, I use nodularity when I don't see a lot of, such thick deposits. Okay. But when I see something as thick as this, I will say there is either caking or I'll say there's sheet-like omental thickening, and I generally give one thickness. Okay, just to give them an idea that it's quite a lot of disease. Okay, because sometimes
Yes.
you'll just see some nodularity like this, right? If I go up here, right, this is nodularity also, right? But this is different, right? This is
Yes.
less nodularity compared to what you see here. So here, caking is a good sort of term to use, or sheet-like omental thickening is the other term I use. All right. So yeah, so whatever
Yes,
is
sir.
here is omentum. What about this? What is this? Is this omentum or what is this?
That is the parietal peritoneum.
Peritoneum, right? So this is peritoneal disease, and that is omental disease. Okay. So we think of everything as one cavity, and it is one cavity, but there is omental involvement, peritoneal involvement, and mesenteric is the center. So there are three potential places where you can have disease. Okay, the most difficult for them to dissect is mesentery. Okay, because if there's anything in the mesentery, if suppose there's something here, you'll have to resect the bowel as well, right? You can't just
Yes,
resect
sir.
here. The vessel will go, which means the bowel in that region has to be resected. Otherwise, there'll be necrosis. Okay, so a focal mesenteric deposit they can resect, but if it's quite a lot of mesenteric deposit, they cannot resect because otherwise there's no bowel left. Okay, omentum is the easiest to resect, right? It's very straightforward. They will all do a omentectomy. And peritoneal disease, yes, that they can resect. So all of this stuff they can easily resect. Okay, so this is a very sort of obvious case where you can see nice deposits as well. But often what you'll see is just subtle nodularity like the one you see here, okay, or even less than
Yes.
that. And then you should search for something like this, right? So clearly there is peritoneal thickening here, right? Maybe not here.
Yes, sir.
Here, can you appreciate it? There's
Yes,
thick.
sir. Yes, sir.
So this is also disease. Okay. So sometimes you'll just see a lot of ascites, you won't see a lot of disease. Then you start searching and you say, okay, I see some peritoneal thickening or nodularity here, and this is disease. So of course, TB can also do this. That's always a differential. But in patients, like this, which has adnexal mass, etc., this is always peritoneal disease. So this is also peritoneal disease. You don't have to always find like obvious nodules like this to call peritoneal disease. This is also peritoneal disease. Okay. So that's omental disease, peritoneal disease. Okay. Now, what is the third compartment I told you about?
Mesentery.
Yeah, very good. The third thing is mesentery. So then they'll ask you, is mesentery involved? And specifically, the first thing they want to know is root of mesentery involved. If the root of mesentery is involved, then they cannot operate. It's inoperable. Okay. So how do you figure out where is the root of mesentery? Are you seeing the root here? Any idea where is the root of mesentery? Um,
At the level of the DJ flexures, a
okay.
little bit more superior.
Okay. So let's trace the DJ flexure. So this is the third part of duodenum. That's the fourth part. And so somewhere here, this is the flexure, right? And then you can see jejunal loop. So, okay, somewhere over here. Now, is it a solitary point or is the root sort of a continuous thing?
The root of mesentery extends from the DJ flexure till the
Till the,
right
very good,
SI joint. Till the
right?
right SI joint.
SI joint, ileocolic, right? I mean, so that's the ileocolic
Oh,
junction.
sorry.
PI and
Ileocolon. Yes.
junction. Yeah, okay. The IC joint is, or the IC is what you would say. Fine. But how do you trace it? I mean, so, I can make out here's the DJ. and I can make out that the IC is, maybe somewhere here, right? But how do I know what is happening here? Is this root or not? Is all of this root? What is root? It gets a little difficult, right? So you know what do you need to trace to figure out the root? And Milan, you can help her if you want to, that's fine. So you need
The
to
vessels, sir.
yeah, good. Which vessel? Excellent.
SMA and SME.
Yeah, that's right. Okay. So the SMA and SMV is what you have to trace. I think the chart is also helping out, isn't it? Okay. So the SMA and SMV is the root of mesentery. Essentially, the SMA SMV will travel along the root. So if you see this is clean, you can see this is nice and having fat in it. Once you see there is fat here, you know that the root of mesentery is not involved. Okay. So you are very confident. This is nice, clean fat. Even a little bit of fat standing is okay. Okay, as long as you don't see soft tissue, it is fine. This is free root of mesentery. It's not involved by disease. Okay. Now what you see here are all sleeves of mesentery or leaves of mesentery. Okay. I'm sure when you have done dissection or you have seen a surgery, you have seen, right? A lot of mesenteric leaves or sleeves are just there, right, hanging around. So that they all arise from the root. So if the root is involved, if you need to dissect the root, you have to dissect the entire thing from duodenum till ileum. Not possible. But if one of a focal sort of involvement of mesentery, yes, you can do it. Now, what do you think is happening here? Is the mesentery fine here? Let's stop here. What do you think? So now here, let me just trace. This is all omentum. Whatever is anterior to the bowel is omentum. Okay. This is peritoneum, and you can see peritoneal thickening here as well. So there is peritoneal disease, there is omental disease. Now their question will be, is the mesenteric disease? Because they will say, I can resect peritoneum, I can resect um, omentum. You told me about the lesser sac. Thank you. That's great. I think I can still resect it, although it will be a difficult surgery. Hepatic hilum, I'll have a look inside and we'll see. Maybe I can resect it, maybe I can't. I'll have to open up and see. But tell me about mesentery, because if mesentery is significantly involved, I will not go in. That's what they'll say. So what do you think is happening here? Where is the mesentery? So I'll ask you, and you tell me whether it's mesentery or not. Is this mesentery?
No, sir, that is omentum.
Okay. Is this mesentery?
Yes, sir.
Excellent. Is this mesentery?
Yes, sir.
Very good. Okay, so this is all mesentery. Everything center is mesentery. Okay, all the fat which is central to the bowel loops is going to be mesentery. All right. Now, what do you think? Is this normal or abnormal? See, with a lot of fluid now, you will see some fluid in the mesentery also. If there's a lot of ascites, you will see some fluid, some fat standing in the mesentery. Uh, but
It is
it's
abnormal, sir.
difficult to be sure what's happening often. But in this case, I think you can give a confident diagnosis. What do you think? Is it involved or
It
not
is
involved?
it is involved, sir.
Yeah, right. So you can see some
There
soft
are
tissue which is enhancing.
deposits.
Excellent. So this is a clear-cut deposit. Okay. So a little bit of fluid is okay. So something like, let's see, something like this is fine. Okay. But this is too much here, and it's not even triangular, right? It's irregular. That means there's something happening there. Okay. So something like this, this is okay. This may be okay. If you see something which is nodular like this or something which is irregular, that is abnormal. Okay, that is disease. Okay, you see this is
Yes.
nodular. You can see this is nodular. I hope you can make out. Let me see if I can mag it. Yeah, you can make out this is nodular and there is some soft tissue enhancement here. Okay, which
Yes,
is
sir.
here also you can see this is enhancing. While this,
Yes, sir.
right, so this is deposit, this may be fluid. Okay, so you have to go a little more in granularity when you report such cases, because once you see that there's a lot of mesenteric involvement, then it's inoperable. They cannot operate this. Okay.
Yes.
So this is one thing you have to again mention. Okay. Then of course you go down, and of course we haven't really gone to the ovaries as yet. But so the adnexa are not, I mean, they're abnormal, but it's not huge masses, isn't it? So there's one here, and there's something here as well. And the most dependent position is going to be POD, pouch of Douglas. So you're seeing
Yes,
deposits.
sir.
You can see these deposits here, can't you? Okay, so so you can see POD deposits, bilateral adnexal lesions, which are, what do you say, solid or solid cystic or cystic? What is it?
They are solid cystic, sir. There are few
So
cystic
when
areas.
there's something solid and when is something is solid cystic, what is the difference?
When
So if I see 90 solid and 10% cystic, what is it? Is it solid or solid cystic?
it's solid, sir.
Okay, so when do you say it's solid cystic?
More than 50% of the lesion is solid.
No. So Sameer has answered it. It's 80%. So more than 80% solid tissue is
Okay, sir.
solid. Okay. Then 80% becomes cystic with solid components. So if you look at ORAS, now they say you have to call it as cystic with solid component rather than the word solid cystic. That's something you should avoid
Yes.
using. But many people still end up calling solid cystic. I don't make any judgments based on that. Okay. Fine. So there are bilateral adnexal muscles which look pretty solid to me. Okay. And there's diffuse peritoneal, omental, and mesenteric disease. Okay. So impression has to say peritoneal, omental, and mesenteric disease. It can't just say peritoneal disease. Okay.
Yes.
All right. So now, you saw nodes here. So now let's also look at RP, retroperitoneum. What do you think?
There are enlarged retroperitoneal nodes.
Yeah. So what is enlarged? What is the cutoff?
So more than
So when is,
more than
yeah, go ahead.
9 in short axis.
Okay. 9, 10, right? I mean, generally it's centimeter. At least that's the one I use. So this is 16 by 8. You can see, or 17 by 8 maybe. So what is this? Enlarged or not enlarged? Assuming you take cutoff at 9, I take it at 10, whatever. Is this enlarged or not enlarged? 17 by 8.
It is enlarged.
So what is the cutoff for? The 9 millimeter is what axis? Short axis or long axis?
Short axis. So this is 8 mm in short axis. So this is not enlarged.
So always remember that the node cutoff is always short axis. So technically this is not enlarged. Okay. So you can say it's suspicious, or whatever, but this is not enlarged. So you shouldn't call it enlarged. So actually the largest node you have seen till now is not RP. It's actually this one. This is the biggest node you are seeing, the internal mammary. Okay. But given
Yes.
the extent of disease and given that there are just a lot of nodes, right? So this is another one. You generally don't see such aortocaval nodes, do you? So it still looks suspicious to me. Okay. So I will call it quite suspicious. You can see some common iliac. So remember, okay, so where does ovary drain? Which nodal group?
The para-aortic nodes.
Yeah, that's right. So say RP nodes, don't say para-aortic. Or you say, if you're asked in your exam, then you can say the left ovary drains in para-aortic. Where does the right ovary drain? Something close to para-aortic, but not para-aortic.
Aortocaval nodes.
Yeah, that's right. So the right will drain to aortocaval, right? So same for seminoma. The left testis will drain to para-aortic. The right testis will drain to aortocaval. Okay, so that's why it's just safer to say retroperitoneum, or you can, you know, uh, call it that way. But, left will drain into para-aortic, right gonad will drain into aortocaval. Okay, so technically pelvis or pelvic nodes, iliac nodes is not something you expect. They can, of course, happen. As I said, ovaries can go to all nodes. But generally, the first thing will be RP nodes, retroperitoneal nodes. Okay. So here you're seeing some suspicious RP nodes. Maybe there's something here, right? You see this common iliac node here. Okay. So,
Yes.
okay. So it's again not big, but given the extent of disease and given that internal memory, it may be involved. So we don't know. Okay. But you can see here as well, right? You can see a common iliac here. So there are common iliac nodes. Definitely there are retroperitoneal nodes. I don't think there is anything in the pelvic side wall per se. I don't see any internal iliac adopted, or maybe there is something here, right? So we don't know. This may also be positive. So RP is the first sort of stop. After that, it can go up, it can go down, it can go anywhere. Okay. Fine. So now
Yes.
sort of have a fair idea of what you want to say in the impression, right? So again, you can see peritoneal thickening here. I think you can hopefully now make out all this disease here. You can see enhancement, right? This is all enhancing, right? So that's what you search for. And here, of course, you can see nice peritoneal thickening also, right? You can see this.
Yes, sir.
So these are all
Yes.
things that you expect, peritoneal disease. You can see something sitting on top of the bladder. Again, this is sort of a dependent site, isn't it? So you can see that there's
Yes,
something
sir.
on top of the bladder. So the more you search in peritoneum, the more you will find. All right. But so what you need to search, just to reiterate, first thing is going to be root of mesentery. You're going to look at the hepatic hilum. You're going to look at the lesser sac. Okay, look at the subdiaphragmatic region because it's very thick in the subdiaphragmatic region. It's not easy for them to get till there. So this again becomes sometimes difficult. Okay, so these are places you specifically look for. All right, because it makes it difficult, and the entire mesentery per se. All right,
Yes,
omentum,
sir.
don't worry. Omentum they will take care of. Peritoneum they will strip everything out. Okay, so they'll do something called a cytoreductive surgery, CRS. Okay, so they'll do, of course, THBS, hysterectomy with salpingo-oophorectomy and cytoreductive surgery, in which they'll remove all of it. Okay, but
Yes.
as I said, in this case, they will not, because of all these, sites of involvement, especially the mesentery. Okay, so they will go for neoadjuvant chemotherapy with the hope that this will shrink. Now, ovarian cancer generally shrink very well to platinum agents, cisplatin, carboplatin, and after that they will give another. They'll give 3 or 4 cycles of that. They'll image again, and now if the disease has shrunken, all of this disease has disappeared, then they will go ahead and operate. If this disease still remains, they will not operate. Okay, or they might give a trial resection and see, sort of open up and see. But generally, if this disease is still there, they will not operate. All right. So at baseline, which
Yes.
is the first time that the patient comes, they're going to ask you what is involved, assuming that there's no intrathoracic involvement. You don't see internal mammary nodes. It's just a peritoneal disease and maybe some retroperitoneal nodes. Then they will consider whether to operate upfront or give neoadjuvant chemotherapy and then operate. All right. If you
Yes.
show them difficult sites of resection, they will prefer giving neoadjuvant chemotherapy, shrinking the disease, and then operating. If overall they think that, okay, there are no very difficult or complex sites, then generally most surgeons, if the slots are available, will operate upfront because it's easier to operate upfront. Okay, so post chemotherapy, it's a little difficult to technically remove the deposits. So one surgeon explained it very well to me. She said that if I operate upfront, these deposits are like stones or pebbles. It's very easy for me to remove them. After neoadjuvant chemotherapy, they are like chalk, they are brittle. So I try to remove them and some of them break off. So it's more difficult, right? But if you show them difficult sites of resection, they will always give chemotherapy first and then operate. All right. So, so that sort of rounds up this case. Any doubts from your end? So I had said I'll sort of show you yeah. So you can see this is a subdiaphragmatic deposit here. Clearly, it's not a surface liver deposit, it's a subdiaphragmatic deposit.
Yes, sir.
Yeah. So coronal helps you in sort of figuring those things out. And here again, sort of you see this deposit here. And that again is probably involving that. So I think it's subdiaphragmatic and of course indenting the liver surface also.
Yes, sir.
That's the first case. And what I have is 2 sort of companion cases. I wanted to basically show you all the sites of involvement, and I think that case just showed everything that you need to look for. But this is a companion case, and maybe now let's ask Milan to answer this one. So Milan, so let's leave everything else, okay? So now just concentrate on the liver and the spleen, okay? So I told you, right, that if I say there's peritoneal disease, it's stage 3. But if I say there is intrahepatic disease, so hepatic metastasis becomes stage 4. Okay, so you'll often
So,
see cases like this. Okay, you see a lot of hepatic, a lot of disease around the river, but then you also see something which looks intrahepatic, right? And they will say if this is intrahepatic, this is stage 4. This is something that we won't operate. Look at this, for example. So what do you think this is? Okay, so everything will depend on what you say. Look at this splenic stuff. Okay, so their question is very simple here. They're going to ask you, is there intrahepatic or intrasplenic disease, which is stage 4 ovarian cancer, or is this just surface deposit, which is stage 3 ovarian cancer? Okay, so what do you think is
yes,
happening?
sir. So there
Yeah.
are intraparenchymal deposits as well.
Like this one, you think?
So this is a surface one,
This is surface.
but
So, so is
so
this deposit, is this cyst? What do you think?
so this is intraparenchymal. So
Yeah, but is this deposit or cyst? If you look at, now I'm windowing it, look, this is gray and this is black. So are you certain this is deposit or can this be cyst? That we don't know. I mean, it could be cyst also, right? But let's look at
yes,
other.
sir.
So this I am not very sure of. Okay, because I see this is all gray. I hope this is projecting well. This is gray, right? And this is not that gray. It's
Yes,
black, right.
it
So
is
you will always
fluid.
want to give benefit of doubt to the patient. So when you're not sure, you will want to give benefit of doubt and not call it met. What about this though? What is happening here? And what is happening here? What is this? What do you think?
So these are deposits. So
Intrahepatic or surface?
intrahepatic. So
Okay. So this is sort of the teaching point for this case, So again, you see something here, but again, I mean, I'm not sure this is really disease. Okay, this one I think could be cyst also. This one, okay. All right, and this one again, I'm not sure. Maybe that's deposit, maybe that's cyst. I'm not sure. What about the spleen? You think there's anything intrasplenic or is it all surface?
So it's
So
all surface.
just to clarify, surface can invade the parenchyma, and that's still stage 3. It's only when there is nothing on the surface, it's pure parenchymal, then we call it intrahepatic. Okay. So what do you think this is? The splenic. Is it intrasplenic or is this surface?
So it's on the surface.
Excellent. Very good. What about this one?
So it's also surface only.
Very good. I like your confidence. Very good. Very good. So, there's one thing in answering correctly and one thing in answering confidently. I think both are very important. And you are answering very confidently. I'm glad to hear that. Okay.
Yes,
So the one thing which I would disagree is that this is still surface. So because this is falciform ligament, right? So what is here is falciform.
yes, sir.
This is falciform ligament, and
Falciform ligament.
deposits along the falciform ligament, and then from there they can invade the surface. That is fine. So this is still for me surface deposit. So my simple rule is anything touching the surface, even if I don't see a lot of deposit, like the splenic one you sort of confidently said is surface, or this one here, which again you said no, this is surface, right? I mean, there's an acute angle here, and someone will say no, this can be intraparenchymal. But my golden rule is that anything which is touching the hepatic surface, I assume it is a surface deposit. It may be invading the liver, but it's a surface deposit. Okay, because then the patient is not palliative, it's still a curative sort of stage 3 patient. All right. So that's
Yes, sir.
so in this case, I would call them all surface. And I would say there are some lesions like this one and this one, which could be cysts. I'm not certain. They are indeterminate, and I'll put a probe and confirm. And of course, if these are not cysts, then this is definite intrahepatic met. But if they are cysts, then sort of rest of it is surface for me. Okay. So that is
Yes.
for this case that this I think many people confuse because the falciform ligament is something we don't think about. Okay, so this is actually falciform ligament deposit invading the liver, and this of course is surface deposit invading the spleen. Again, talking of all those sites that we talked about, you can see that this is going to be very difficult to resect. Why?
So there is hilar involvement, periportal
Yeah.
deposits.
Yeah, and this is much more, right? This is much more than the
Bigger deposits.
hilar involvement. You can actually see encasement of the main portal, can't you? And this is the main
Yes.
portal. You can see soft tissue all around it, and that's impossible to resect, right? It's extremely difficult. So this one, of course, will go for neoadjuvant. And again, now you can see clearly enlarged nodes, right? So there are a lot of enlarged nodes here. Okay, so this patient is unusual in the sense you can see even inguinal nodes, can't you? So you don't see a lot of you see a lot of peritoneal disease, not a lot of ascites. You can see deposits here. Okay. But not that much ascites, and you see a lot of nodal disease burden. Okay, so it's not an easy one to operate because even the nodal disease, you can see it's sort of pretty close to major vessels, right? So the left renal vein is sort of abutted, and you can see the left renal artery is again probably encased by more than 180 degrees, right? So it's a difficult one for them to operate. So of course here they'll go for neoadjuvant. Okay, nodes is different, right? So here I'm seeing a lot of nodes. Sorry, mesenteric nodes is different, is what I meant. So mesenteric nodes I tend to ignore. Okay, these I will not call as deposits or metastatic nodes. These I think are okay. But anything here is quite suspicious. Okay, I tend to undercall mesenteric nodes basically, which is different from mesenteric. Okay, so like this mesenteric deposit here. This one is not a node. This looks like a deposit. It's irregular. But some of these, like this one, they are nodes. Okay, so. So nodes like this one, again, you can see it's kidney shaped, it's a node. So nodes in the mesentery I tend to undercall. Okay, most of them are not metastatic. Okay, and try to differentiate that from deposits. All right. You're talking, you're saying something?
Yes, sir. So my doubt was the same only that if we see mesenteric lymph nodes, so whether it is due to the disease deposits or whether we can ignore it.
Yeah. Generally, I would say ignore it. The only exception is if it's a colonic cancer. Okay, so colon cancer or small bowel cancer will obviously drain into the nodes. They are draining nodes. In that case, you are more worried if it's the drainage area, right? So otherwise, I would always ignore mesenteric nodes. The other, of course, cases when they're obviously like huge, right? Lymphoma and node adenopathy related to that is very obviously abnormal. But if I see nodes which are prominent, not more than that, okay, I will always ignore them in the mesentery. Okay.
Yes, sir.
So the third case is slightly different, and maybe you can continue because Aparna spoke for long. And here there's just one thing to sort of know, I would say, more than anything else. So again, you see disease. Okay, this is also ovarian cancer, but there's something different here. Okay, you don't see a lot of disease below. That's sort of the right adnexal mass. And you see something here. So what's happening? What is different here?
So are there hypervascular deposits, sir?
Okay, that's a good thought. It could be hypervascular deposit. What's the other thing it can be? So when you see hyperretinating content on in contrast enhanced scan, what are the sort of things it could be? One is that they are hypervascular. What is the other thing?
Calcifications, sir.
Calcification, very good. And the third thing would be hemorrhage. Right? These are too bright for hemorrhage. So probably in this case, not hemorrhage. So what do we do to differentiate calcification from hypervascular meds?
Non-enhanced scans,
We
sir.
have that. So now what do you think?
So these are calcifications.
Yeah. Yeah. So you see a patient with ovarian cancer with, again, otherwise sort of classic deposits in the sense you see perihepatic, perisplenic, but they are quite calcific, aren't they?
Right,
Right?
sir.
You generally don't see so much calcification. So when you see so much calcification, do you know what is the diagnosis? It is ovarian cancer, but it's a specific subtype of ovarian cancer.
So mucinous.
No, 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 not mucinous. So mucinous may calcify to some extent. It won't be so diffuse calcification. Okay, mucinous can have some foci of dystrophic or calcification or punctate calcification, not something so diffuse sheet-like. So what is the most common ovarian cancer to show calcification? Is it mucinous? Is it serous? Is it clear cell? Is it endometrioid? Which one? Now, this is something you must have read in Robbins.
Uh, Sir, serous.
Okay, excellent. That's the correct answer. Why? So there were certain bodies, if you remember, classically seen in thyroid cancer.
Samoma bodies.
Samoma bodies, very good. So there are three tumors which have Samoma bodies, as far as I remember. There's meningioma, there is thyroid, and there is serous ovarian.
Serous adenoma.
Yeah. Serous ovarian tumors, basically. Right? So
Yes.
so these are all Samoma body related calcification. The hint is if you see a lot of it, it is low grade serous ovarian. It's not high grade. Okay. So when you see this is always when you see such diffuse calcification. I'm not saying that high grade cannot have some calcification. It can still have some focal areas of punctate calcification, but not something so diffuse. If you see something so diffuse, then sometimes it can be completely white also. Then it's always low grade serous ovarian cancer. Okay, which is a very distinct subset. Okay, because it is not that aggressive. Okay, so when you see this and you say it's low grade, the patient's prognosis is much better. They will live for decades. Okay, a high grade serous will eventually, progress and die in 4 to 5 years max, usually on an average. Low grade will live easily for 8 to 10 years, even 15, 20 years easily. Okay, they have much better prognosis. And second, because they're low grade, they're not dividing, which means chemotherapy won't help. You have to operate and remove them. Okay, chemo will only kill dividing cells. So platinum-based chemotherapy doesn't help in low grade, or at least not as much. Okay, so this is just to show you that when you see this, you think of low grade ovarian cancer. Okay, all of these are deposits, and it's all related to low grade ovarian cancer. All right.
Yes, sir.
So, oh wow. So we just did peritoneum and it's 7:46. So maybe we can do one more case and then call it a, we can continue it some other time. So let's, yeah, why don't we do adnexal 1 and adnexal 2, right? I mean, let's just do that. So this one is slightly more complicated. So both of you are second year, right?
Yes, sir.
Okay. So why don't you continue with this one and then she can take the last one.
Sure, sir.
Okay, so this one, the heads up is that I didn't get the diagnosis. Okay. One of my residents was very confident of the diagnosis. I wasn't that convinced. All right. So this is a young lady. This is a 20, I think around 30-year-old lady. And she comes with this. Okay, so ignore everything else. Don't worry about peritoneum. Don't worry about anything else. Just look at the mass. Okay. Sorry, she's not 30. I remember now. She's around 50. She's around 50 to 60 years. Okay, my bad. She's around 50 to 60-year-old lady, and this is what we see. Okay, it's not an easy case. But what do you see?
So there is irregular
Hmm.
thickening, circumferential thickening of the uh, sigmoid.
Okay, so let's okay. So here's the rectum. You go up, up, up. Rectum, 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 rectum. That's the sigmoid. You're going, and then that's the sigmoid. You see the sigmoid?
Yes, sir.
You think it's thickened?
Mm, no, sir.
Not really,
Just
right?
before this.
Yeah. So this
Yes.
is all sigmoid, I know. You're tracing it, right? This is sigmoid, sigmoid, sigmoid. And it's going here. And then you can trace it further, it's going here. So this is not sigmoid, is it?
Okay, right. So it's
Right.
something.
It's something
It's
else. I mean, I agree. It
yeah.
looks like bowel and there's species, but whatever it is, it's not sigmoid. It may be some other bowel. It may be something else altogether, but it's not sigmoid. Okay, so we'll search where else does it involve bowel, or where do you see sort of something involving bowel? What do you see? Okay, so see in the pelvis, there is rectosigmoid or the sigmoid basically. Sometimes if the transverse colon is very redundant, it can go to the pelvis. Otherwise, what loops are in the pelvis? Ileal loops, right?
Yes, sir.
Sometimes appendix can be sort of pelvis. So those are the places where you would look for if you are seeing something which is bowel-like and in the pelvis. Okay, so here's the cecum. Okay, that's the appendix. Hannah, isn't that the appendix? You see the appendix here? It's a little thickened, isn't it? But do you think that's going into the mass? What do you think? I
So
hope
it
I.
is abutting the mass,
Yeah.
in
Yeah.
but not exactly connected to the mass.
Yeah. Again, so you're not convinced that this is a mass arising from the appendix. Okay. Like, certainly the appendix is abutted, but not look. It doesn't look like arising from the appendix. And the other thing I said, transverse colon is not redundant at all. It is right over here. And the other thing I said is then pelvic ileal loops, right? So now look at the ileal loops and let's see if we can find a communication somewhere or connection somewhere with the ileum. What do you think is happening here? Trace this loop.
Yeah, so there is some so there is one communication with the
Yeah.
posterior part of the loop, so
Right. Okay. Very good.
and this is a enhancing collections with heterogeneous content with them.
Yeah. Yeah. But there is heterogeneous content within it. So are you sure it's a collection or can it be a mass? Right. So the first question they'll ask you. So you tell them, you call the doctor and say, listen, there's something abnormal happening here. And this patient has come with tenderness. Okay. And you say, there's something I see which is very weird looking. And he'll say, is it cancer or is it benign? So are you sure there's no cancer or there's no mass? Or could it also be mass?
So it could be mass because of the thickened uh,
Excellent. Right. So this is
enhancing
soft tissue. Right?
also.
This is soft tissue, right? This is all collection, agree, or fluid, whatever. But this is not fluid. This is some soft tissue here, right? Okay. And even this looks pretty thickened, right? So we are not sure. We cannot rule out a mass, right? At least right now. Okay. So, but
Yes,
what's
sir.
happening? So why is there all this gas and this weird appearance? This appearance made you think of colon, didn't it? That's why you thought this is a sigmoid mass, right?
Right, sir. Sir, this could this be like aneurysmal dilatation of the wall, which we see in lymphoma?
Yeah, that's a good point. So generally, what you are seeing is basically something which is communicating with the ileal loop. But does all of this look like, is it continuing with the ileal loop? Maybe this part is, right? This part you can see it's continuing here, this thing, right here. So this here, 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 here. It goes inside this. You see this? So it's
Yes,
involved
sir.
there, but is the bowel dilated or what? All of this is, I mean, this is not looking like bowel to me. I don't see any bowel wall here.
So
I see
it's
something.
exophytic.
Yeah, it's more like exophytic or something like that. So aneurysmal dilatation of lymphoma is a good thought. Generally, they are more homogeneously enhancing, and generally you can make out that there is, circumferential bowel wall around it. Generally, not always, but generally. Okay. So I would keep that lower down in the differentials. Okay. So what else? So when do you see? So you said collection, right? Which means you're thinking of something, some sort of a local perf, right? Something in which the bowel is involved, something which is involving the bowel, and that's where you see all this gas, right? So, what else do you see? So let me do one thing. Let me change the window. Okay, what else do you see here?
So there are calcifications within.
Yeah, right. So calcification is something could be because of bowel content also. There's communication with bowel and maybe something hyperdense is calcified. But this one looks like what? Does it look like calcium? What does it look like?
Oh, some some ingested material. I mean,
Not that much. I mean, you look at this, there is something around which is more sort of hyperdense, and something in the center which is less hyperdense. What does this remind you of? It reminds you of calcification. It reminds you of metal. It reminds you of ossification. It reminds you of lipoidal. What does it remind you of? All sort of hyperretinal things. Amongst all of them, what does this appearance remind you of?
so ossification.
Ossification, correct? Right. This looks like cortex and medulla to me, right? So it looks like ossification. I mean, maybe not tooth, but at least bone is what I can say. Okay. And once I think that, then what is the other thing it is can be? And even over here you see something, right? This thing.
Yes.
Okay. So so here's essentially, so see, here's a thought process. Okay. Are we convinced this is arising from the bowel, or do we think it's something else involving the bowel?
So it could be that the mass is just now communicating or
Yeah.
has developed fistula with the vowels.
Yeah. Yeah. So it could be a tumor bowel fistula. There's a tumor or there's some mass somewhere which is involving the bowel. Okay. It doesn't look like a primary, in the sense, it doesn't look like a lymphoma or adenocarcinoma arising from the bowel. So a gist is one thing this could have been. Gist can be exophytic from bowel, and of course it can, fistulize with the bowel and do all of this. So a gist is one thing which is possible. But when you see ossification, what is the other thing which can develop in the pelvis, which has bone?
So teratoma.
Yeah, teratoma. But can a teratoma do this? I mean, you've seen so many teratomas. Can it do this?
No, sir. A mature teratoma won't cause communication.
Yeah, it won't do this. But then can there be something which is related to a teratoma which can do this? Or when can a teratoma do this? Let me ask you that way.
So malignant teratoma.
Yeah, good. So what is a malignant teratoma? So what components does a teratoma have? There are these three components, right? What are they? Ecto, meso, and endoderm, right?
Endoderm. Yes, sir.
So all these three components, right? So that's when it's a teratoma, right? So, and usually you'll see teeth, you'll see bone, you'll definitely see fat, and you may see any other component. Immature teratoma will have neuroepithelium. You can have squamous epithelium. You can have thyroid, and you remember struma overi, right? I mean, that's a thyroid secreting sort of teratoma, right? So any of these components can eventually, in a long-standing teratoma, undergo malignant degeneration. Okay.
Yes,
I'm
sir.
sure you've read of this, right? So struma overi is one thing we all remember, but any component can do it. The most common component to undergo malignant degeneration, do you know that?
Epithelial, sir.
Epithelial, yeah. And which is the most common cancer, which then arises from this epithelial component, is
Squamous cell carcinomas.
squamous, right? Because that's what we often see, squamous component. Right? So this could be a teratoma, long-standing teratoma. So you won't see it in a 20 or 30-year-old. Okay. So with teratomas, the longer standing they are, the more likely that they will undergo malignant change. So in a 20 to 30-year-old, it's not going to happen. In a 50 to 60-year-old with a teratoma which has not been excised, there is a possibility that there will be malignant degeneration or squamous carcinoma rising from the teratoma, and that could involve this. Okay, and that is what has happened here. Okay, so this is basically, and
Yes,
the
sir.
is this bone. Okay, so this was a resident of mine, Pooja. She had seen this. She insisted this is teratoma with um, secondary involvement of the bowel. I said I agree that secondary involvement of bowel, there's a mass. I'm not 100% sure this is teratoma. It could be anything. Okay, but she was right. This was teratoma. All right. So this is
Yes, sir.
it's a more niche case, but just to show you the approach. When you see something like this, your mind just freezes, right? But then you have to scroll, first figure out it's not sigmoid, then figure out, well, I don't think it's actually a primary bowel tumor, or at least lymphoma or adenocarcinoma of the bowel. And then you think of what else can do this. Okay. So this could have happened in any pelvic mass, which is involving the bowel secondly, but the bone makes you think it's a teratoma. Okay. I
Yes,
think,
sir.
yeah, let's do this one last case. This is a short one. Yeah, so Aparna, you are back now. Okay, so this is a patient who's under right hemicolectomy in the past. Okay, for a cancer. Okay, you can see that the right colon is absent, right? So she's undergone a surgery in the past, hemicolectomy, and now I think I can show you the history. I think I've kept it open actually. Hold on. Yeah, here it is. Cecal mass resected, 35-year-old female. It was a T3 tumor with some peritoneal disease. Okay, there was some peritoneal disease. Sorry, it was a T4N1. Okay. And now this is a CT done as a follow-up. So she's been treated completely. 2018, the treatment is over. She's cancer-free right now. Okay, all her chemotherapy is done, surgery is done. She doesn't have cancer. She comes, there's the scan. And this is what the report, I think it's an outside scan. The report said liver hemangioma, let's leave the hemangioma, and an adnexal mass in the, which, makes you worried, right? Adnexal mass. Could it be Krukenberg? Or could it be some other primary? We know that the HNPCC tumors HNPCC patients can have both colon and ovarian masses, right? So now here is the scan, and let me actually open the things for you. Okay, so this is what the outside report said. Okay, then the patient came to us, and this is what we see. All right. So ignore everything else. Just look at the adnexal lesion. All right. And so this is the lesion. It's on. So it's what do you think? The right adnexa is fine. Nothing in the right side, right? It's just a left adnexal
Yes.
mass and the POD, right? There's something in the POD as well. Okay. Now, what do you think is happening here? What do you think this is? So they're going to ask you, is this cancer or is it not cancer? Is this recurrence or another primary cancer, or is this not that? What should we do next? Should we open, operate? Should we biopsy? What should we do next? So, this one, if you know the answer, just blurt it out. If you don't, then try and describe the
So
findings.
because there is a history of surgery prior to this, and it looks like a peritoneal inclusion cyst.
Excellent. Very good. So why do you think it looks like a peritoneal inclusion cyst? What makes you think so?
Because it is cystic with no solid component, and it is insinuating along the adnexal structures, the the left fallopian tube, and
Good. Very good. So, basically it will follow the contour of the pelvic cavity. So a mass will be round or oval or whatever. But this you can see right from here, it is following the contour of the pelvic cavity all the way, right? And that a mass will never do, right? A mass will never follow the contour of the pelvic cavity. It will push things around it, not follow the contour. And then what is the classic thing? Why does a peritoneal inclusion cyst happen? So you said there's history of surgery, and I see this, and hence I'm calling it a peritoneal inclusion cyst. Why is the history of surgery important? Others will say history of surgery makes me worried because there's history of cancer. So why is this not cancer? Why is this a peritoneal inclusion cyst?
but there can be adhesions which form, and then fluid will get collected within the locules, and then it forms the
Why
inclusion.
will fluid collect only here? Why not elsewhere? So you can help him if you know the answer. Sorry, Milan, you can help her if you know the answer.
Dependent.
Could it be due to dependent positions?
See, what is the most, so if it's a dependent position, POD makes sense, right? After POD, it will go to paracolic gutters, right?
Right, sir.
And it will go in the hepatorenal pouch. All of that is clean. Okay, so it's okay. If you don't know, then I'll tell you because it's not something you can guess. But basically, there are adhesions. Every cycle, every menstrual cycle, the ovary ends up secreting some fluid, doesn't it? Right? So whenever the ovary secretes fluid, with every cycle, what you see is the fluid gets stuck in those loculations. So with time, this becomes an inclusion cyst, and the ovary keeps sort of keeps secreting, so it keeps growing slowly in size. So the classic thing for a perineal inclusion cyst is two actually. One is, of course, that will follow the contour of the pelvic cavity in a patient who has history suggestive of adhesions, meaning prior cancer, prior TB, prior infection, inflammation, something which causes adhesions. And the second is you have to see the ovary, right? This is the ovary. So you have to see the ovary in, generally around the periphery of the mass. Okay. So this is the ovary here. You can see it's in the periphery of the lesion. So the ovary will classically be in the periphery of the lesion and it will continue to secrete. And that is why you will always see this sort of increasing sort of collection. Okay. So both these things have to be there. And if you don't see the ovary on CT, do an ultrasound, you will almost always see the ovary. Okay. But this is always, it's a very classic thing. And I'm glad you said the right answer. But you also need to know why is it happening. And you have to look for the ovary, right? So the correct answer is follows the contour and I see the ovary in the periphery. And hence, there is no doubt in my mind that this is a peritoneal inclusion cyst. Right? So the patient will come and tell you, don't you think this is cancer? Should I get a biopsy? Should I do a PET? Okay, the doctor will call you, listen, if this is cancer, even 1% chance, please let me know. I can still operate this. And you have to say, no, this is not cancer. This is peritoneal inclusion cyst. All right, excellent. So every month we'll see one such case in Tata coming from outside, which, is being labeled as, as which is peritoneal inclusion cyst, but has been labeled as cancer for some reason. Sorry. Where were we? Yeah, we are here. Okay. So, great. So it's past 8. So we could only do the peritoneal cases and the head neck cell. So what we'll do is the rest, maybe I can do the next time we have a Saturday night vacant. I can take that. If there are any questions, put them on the Q&A, please. Because there's too many things in the chat box for me to be able to. Yeah, so Bhumika wrote this, entrapped ovarian size. That's the perfect term, right? So the ovary is entrapped and secretes fluid and it gets stuck. So that's the peritoneal inclusion cyst. So now a lot of background noise is coming from my end because of Durga Puja.
Sir, so that means male patients can never get a peritoneal
No.
inclusion.
That's right. That's great. Perfect. The male patients will not get it. In the sense they will get, they can get loculated peritoneal collections, yes, but not the inclusion cyst, which is secondary to the entrapped ovary. Okay.
Okay, sir.
All right. So please repeat solid. So Bushra, kindly go through all 13 areas of peritoneal cancer index. Bushra, that's crazy. Yeah, that will take a lot of time. Let's do that another time, Bushra. Okay. So Vrinda, please repeat solid cystic part. So anything more than 80% solid component, Vrinda, is considered solid at nexal mass. Okay, how to delineate the lesser sac on CT? Bethlehem is asking this. So this I can show you again. I think, so I should actually show you my approach in the sense, what do I look for? And let's, I sort of thought I'll do it and then somehow missed showing you that. But let's do that. Okay. So lesser sac is very simple. Anything behind the pancreas, behind the stomach, anterior to the pancreas. So all of this is lesser sac, right? So all of this is lesser sac. The so the lesser gastric artery is one way to sort of identify it. You look at the celiac trunk, right? That's here. This is celiac trunk, right? So with the celiac trunk, you will see the hepatic branch, the splenic, and the lesser gastric artery, and all of this is going to be lesser omentum, right? Where the lesser gastric artery goes. So that's part of lesser omentum, and all of this, which is behind the stomach, anterior to the pancreas, is lesser omentum. So all of this stuff is lesser omentum. The classical teaching is the foramen of Winslow is sort of the right lateral margin of the lesser omentum, and that's where the common hepatic and the bile duct will traverse. right? So all of this is going to be lesser omentum. Okay, yeah. So what I do is always look perihepatic, subdiaphragmatic, perisplenic. These are common sites. Always look left upper quadrant. That's something I used to miss earlier. Okay, there can be subtle deposits in the left upper quadrant. Okay, omentum, I think all of you catch very nicely. Omental deposits. Look for this peritoneal thickening everywhere. Okay, that's very important. I won't say it's very important clinically, but it's nice for you to catch it, right? I mean, even if you miss it, they will operate and they will be able to resect it, but you should catch it. This is very important. Look at the mesentery. It's sometimes a very soft call. It's very difficult. So here it's very obvious. We can see deposits. Sometimes it's just some minimal standing and fluid. And those times I will not call it as deposits. I will undercall it because, you don't want to make the patient inoperable. You can say that, listen, I'm not sure. Perhaps give neoadjuvant chemo and then we'll assess again. But if after assessment also it's 50-50, they will always go ahead and operate and figure out intra. Okay, so that's still the omentum here. That's still the peritoneum here. That's still the mesentery. And then as you go down, this becomes sort of the mesocolon now, right? So this is all mesocolon now. Okay, and then POD. So POD will often have deposits because this is the dependent site. So look very carefully at the POD. So at baseline, it's very easy because baseline, what happens, there's a lot of disease. They will operate this patient. The patient will go into follow-up. The patient CA125 will be normal. And then after maybe a year or two, usually, between 1.5 to 2 years, the patient will come back with rising CA125. Now the marker is 70, 100, 120. And then they'll ask you, they are sure there's disease recurrence somewhere. Where is the recurrence? And that time, often it's just some subtle nodularity here. So that's when it gets more difficult, and you have to really look at everything very carefully. And nodes, as I said, look carefully at all nodes when you look at ovarian cancer. Okay. Yeah. Anything else in the Q&A? Let's see. Where is the Q&A? Yeah, here. Okay. Oh, that's a lot of questions. Okay. So Bethlehem cutoff for enlarged node is, so Bethlehem for me it's 10 millimeters, but it's sort of a arbitrary cutoff, right? So it's not like pelvic nodes, maybe even 8 millimeters is okay. If I see a round node which is 9 millimeters, I'm more worried than I see an oval node which is 10 millimeter. So it's a lot of things. It's not just the size. And it's not true for all nodes, right? So retrocrural nodes, even 6 millimeters is abnormal. Intermammary nodes, even 6 millimeters, 5 millimeters is abnormal. Okay, so it will vary from site to site. You mentioned the omentum is located anterior to the bowel loops. That's right. It's located anterior to the bowel loops. How to differentiate cholangiolar abscess from med? That is not what was discussed here. Anonymous attorney, sorry. So we can discuss it next time. But the answer is often you cannot differentiate. But if there's fever, you assume it's abscess. If there's no fever, you assume it's met or you biopsy. Orkun is asking if lesion originates from surface and extends into parenchyma, what should I call them? Yeah, Orkun, then you say surface hepatic deposit, which is infiltrating the parenchyma. And that is still stage 3. It's not stage 4. Okay. So that's still something which is stage 3. Visar is kindly comment on splenic met again. So again, surface splenic lesion invading the splenic parenchyma or apparently invading the splenic parenchyma. That's still surface deposit. It's not intrasplenic met. Okay, with ovary or with most cancers, it's very, very uncommon to see intrasplenic met. Okay. So almost always I don't worry about it. Can post-therapy status have calcific mets? Yes, they can. In fact, calcification can develop post-therapy, but that diffuse calcification that I showed you is always low-grade serous. Okay, that diffuse amount of calcification will not happen post-therapy. It will be some fossa punctate dystrophic calcifications. Okay, so that sort of answers the next question also. Bethlehem, how do you differentiate ossification from calcification? So calcification is extremely dense, HU-wise, right? Ossification is cortex plus medulla, right, Bethlehem? So the case I showed you, there was a peripheral cortex and a central medulla. So that way you can differentiate. Peritoneal inclusion is mesenteric cyst. So mesentery will be more higher up, right? It's sort of in the mesentery. So that will be higher up. And peritoneal inclusion cyst is basically, there's usually history of some surgery or sometimes TB or something like that. Okay, anonymous attendees, percutaneous biopsy, rational C ovary with unknown ascitic cytology status. Yeah, it is. So the question is a good one. Basically what happens, see, if C ovary, if it's limited to the ovary is stage 1. Okay, if it's spread into the peritoneal cavity, if it's pelvic peritoneum is stage 2 or bilateral is stage 2. If it's spread beyond the pelvic peritoneum is stage 3. Okay, so primary ovarian tumor is stage 1 and it's called stage 1A. But if you biopsy primary ovarian tumor, it becomes stage 1C because there is a chance of you having seeded the peritoneum at the biopsy site. Okay, so if we biopsy what is a pure adnexal lesion without peritoneal disease, then, and it was actually just stage 1A. When you biopsy, you made a stage 1C, you have worsened the prognosis. So we generally try to avoid biopsying an adnexal mass. But um, sometimes, if there's no other, so if there's ascites present, you will first tap the ascites. If the cytology is negative, you're not sure whether it's metastatic or not. Then what do you do, right? I mean, one thing is you just operate the patient upfront. But many times, you don't want to operate a patient for, say TB. What if that's TB? It's not cancer. It's a tuberous abscess with peritoneal sort of fluid. In such cases, you will still biopsy. So that's something you have a discussion with the referring gynecologist. And if they feel that you need to biopsy, you can do that. Okay, Asad is asking, do you use oral contrast for staging C ovary? That's an excellent question, and the answer is yes, you always do it. So C ovary, and that's one thing I didn't show you actually. Maybe next time I can. Has also a propensity for, let's say, two more things. One is abdominal wall deposits, and one is serosal bowel deposits. Okay, abdominal wall deposits, look very carefully in C ovary for abdominal wall. That's sort of one of the other search pattern things you should remember. Look at the abdominal wall. But also bowel serosal deposits. So see deposits which are involving the cecum or the colon or the small bowel. And sometimes it's not that easy if the bowel is collapsed. Because you're not sure, is it a serosal deposit sitting on the bowel or is it just collapsed bowel? So that is the reason why you would always try and use oral contrast, because that can help you. And I have a case which demonstrates that. Let me see if I can find it. It's in my contrast talk. First thing is, how do I find my contrast talk? Yeah, I think it's somewhere here. I think it's this one. Let's see. Let's hope this is the right one. But if it is, I have a lovely case to explain what I was just saying. I hope you are able to see the screen. Yeah, here it is. Okay. So are you guys able to see the screen?
Yes, sir.
Okay, great. So yeah, you can see here, right? This is the older scan. And now, are these deposits or is this collapsed bowel? It's difficult, right? But see, actually, this was collapsed bowel and this is deposit, right? And there's no way you could have figured that out without the oral contrast, right? Here, you can call all of them deposits. Here, this is collapsed, this is bowel, and this is serosal deposit sitting on the colon, on the bowel. Okay. So that's why you would always try and give oral contrast for any cancer with any patient with suspected peritoneal disease, I would say. Okay, not necessarily just ovarian, any patient with peritoneal disease. Okay, were there any more questions? I think there are still some questions. So, Vamshi, where is the ovary present? Usually at the periphery of the peritoneal inclusion cyst. Peritoneal inclusion, does it continue to grow? Yes, it does, because the ovary keeps secreting fluid. Let's ignore this. Which ovarian cancer has calcific meds? As I said, low grade serous will have diffuse calcification, Vrinda. If it's high grade, it can still have calcification, but not diffuse. Vamshi, criteria for solid dose cystic, this we already discussed. Can we raise gossipima? Excellent question. Yeah, so that's always a possibility. Gossipima is exactly something that looks like that. But there was no history of surgery, so we didn't. If there was history of surgery, yes, you can. Ideally, you should first look for, generally the gauze will have a radiopaque line. If you see that line, you know it's gauze. If you don't see that line, there are gauze pieces in use which do not have the radiopaque line. So you still can't rule it out. And then you have to call the surgeon and discuss with them. Atharva is asking, why use positive contrast? Because as I showed Atharva, you need that bowel distension. You can use neutral contrast also, fair enough. Not necessarily positive contrast, but you would use oral contrast. Rajat is asking, besides the reniform shape, anything else to differentiate node from mesenteric deposits? The reniform shape, presence of fatty hilum, ovoid shape, I think is enough for me. Ovoid, oval, generally I will ignore them if it's mesenteric. Okay, they're generally not deposits, they're nodes. Okay, anyway, with a lot of peritoneal disease, you expect reactive adenopathy, right? Also, so that's what it generally is. gastrohepatic ligament I showed you, right? That's part of the lesser omentum. Hanuman is asking identification of ovarian origin. I mean, I didn't get that question, Hanuman. But the right left adnexa, you generally see the mass there. Farin is asking caking of lesser omentum or deposits. So, that's more of a, I mean, you can call it whatever you want. You can call it caking, you can call it deposits. My general thing is I use caking only omentum, of greater omentum.